Hello everyone, my name is James Bentley and today I'm going to be presenting our group project, Improving Quality of Care in the Emergency Department, which was a collaborative effort among Meredith Bayard, Sarah Fitz, Michelle Miller, Brooke Wickman, Aaron Wright, and myself, James Bentley. Our group, a team in the emergency department of a Midwestern hospital, has been challenged with complaints of a general lack of sensitivity of staff to patient needs and inadequate services. Changing community demographics, including a large influx of immigrants and refugees, especially from Syria and Somalia, has challenged staff who were not previously accustomed to language barriers, state and federal insurance programs, poverty, and varying religious beliefs. Patient satisfaction surveys have shown that when people of other cultures are seen in our ED, they do not feel that staff are equipped to meet their cultural needs and do not have adequate training to do so. Moreover, compounding the existing issues in the ED is an increasing rate of non-emergent visits to the ED. These visits can be attributed to the poverty, housing instability, and food insecurity in the community. These non-emergent visits have led to understaffing, exhaustion, and poor morale among staff, and reduce the availability of resources for patients with truly emergent complaints. Here's a quick video showing a part of what our emergency department is currently dealing with and will address.
While TennCare patients are costing taxpayers tens of millions of dollars for what are often unnecessary trips to the emergency room, health experts say they're just a small part of a much larger problem.
Our community watchdog investigation found that problem cost taxpayers in Tennessee almost $85 million in 1 year alone. And Nate Morabito discovered this isn't just a TennCare issue.
Yeah, from private insurance to Medicaid and Medicare, people are not always using the emergency room for actual emergencies. We're talking life or limb-threatening injuries. They're using the ER for things a primary care or urgent care doctor is better trained and suited to treat. Severe burns, seizures, sudden dizziness, slurred speech, chest pain, among specific health problems that require an immediate trip to the emergency room. But our investigation found plenty of people on Tennessee's Medicaid program are using the ER for toothaches, lower back pain, and nausea, even a common cold.
It isn't just a Medicaid problem. It's across the country. All different insurers and states are struggling with this issue.
And it's costing us all money. Almost $85 million in 1 year alone in just TennCare expenses. Consider this, the same common cold that Medicare pays a doctor's office or urgent care facility $92 to treat costs taxpayers $264, almost 3 times as much when the person goes to the ER. TennCare reports it funded almost $5 million worth of ER trips for viral and acute upper respiratory infections in fiscal year 2016. That's more than 33,000 ER visits that a family physician, not an ER doctor, could have and should have treated.
In the TennCare population, it's upper respiratory. In our Medicare population, it's urinary tract infection.
Like TennCare, Mountain States Health Alliance is targeting specific patient groups to try and encourage them to treat most of their health problems, including chronic ones, outside of the ER, where they can receive more effective, continuous care.
This is a long-term problem.
A 2014 Centers for Medicare and Medicaid Services bulletin suggested 3 strategies for reducing non-urgent use of emergency departments. Those strategies include broadening access to primary care services, focusing on frequent ED users who make up 4.5 to 8% of all ED patients, but account for 21 to 28% of all visits, and targeting the needs of people with behavioral health problems.
I think we need to do a better job of letting everybody know more widely why that's important. Why is it important to seek care in the appropriate setting?
Experts say when appropriate care is delivered in the most appropriate setting, people receive better care at a lower cost. Nate Morabito, News Channel 11, in your corner.
So one of the things
To address the aforementioned problem in the emergency department, our team integrated concepts from Studer's Build the Foundation and Cotter's Leading Change models. Using these models as a guide, we created a work plan which ignites passion among the staff, facilitates buy-in at multiple levels, utilizes interprofessional collaboration, and most importantly, generates results. We have 4 goals for our project. First, we want staff to feel that they have adequate training and resources to safely and effectively provide high-quality care for patients. We will assess this goal using a survey developed by the project steering committee so that pre- and post-test intervention scores can be compared. Our second goal is that the cultural, religious, and socioeconomic status of patients informs the provision of their care. Third, we want high-quality primary care to be accessible to all in the community. Finally, we want all non-emergent ED visits to be reduced by 75% within the first 2 years. The first part of our work plan involved bringing attention to the problem. While the staff may have been well aware of the issues, it needed to be presented from management so that they were aware of the issue and wanted to work with staff to correct the problem. This would then hopefully make the staff feel involved and want to help solve the problem with management. We also wanted to make staff feel good about the job that they are currently doing and remind them why they got involved in healthcare in the first place. The EMS director and the PIC director first collected at least 2 weeks of data regarding changing patient demographics, reasons for visits to the ED, and remarks from recent patient satisfaction surveys. Management, including charge nurses, then presented this data to staff during multiple shift huddles, held at 7 a.m. and 7 p.m. on multiple days to let all the staff know about the concern. The second portion of the work plan involved facilitating staff buy-in and forming a team approach to the problem. To do so, staff were surveyed about the most important areas of change. Additionally, within 1 month of project initiation, the EMS nurse manager and EMS lead nurse practitioner held a series of staff meetings with the various nursing shifts to discuss changes in the work environment and help staff understand the work plan and be engaged in the change process. Part 3 of our work plan involved creating the vision for our department and getting feedback from staff about the plan. Our vision was centered around the 5 pillars and 9 principles from Studer's Build the Foundation concept. The 5 pillars are service, people, quality, finance, and growth. The 9 principles include commit to excellence, measure the important things, build a culture around service, create and develop leaders, focus on employee engagement, build individual accountability, align behaviors with goals and values, communicate at all levels, and recognize and reward success. By implementing these tools, we further engaged staff and got to the root of our problems while also focusing on our patients and their needs. This occurred within the first month of project implementation and continued quarterly with EMS management rounding on ED staff to hear their concerns. Part 4 of our plan included clearly communicating our goals with the staff as our plan continued to develop. This includes non-nursing staff in the ED, such as respiratory therapy, registration, and secretaries in the department. This was led by the EMS nurse manager and lead nurse practitioner who disseminated the changes to the staff at change of shift huddles and staff meetings. For continued updates, monthly updates were sent to all staff by email about the measured metrics and the trends that the group is seeing. This helped give a personal feedback to staff and help them have accountability for the project's success. Establishing accountability for staff participation was crucial. Educational sessions were developed and nurses were required to attend. These sessions were led by the nurse manager in collaboration with the social work team. A logbook was utilized to allow staff to record potential obstacles along the way. The nurse manager held the responsibility of reviewing these obstacles, brainstorming solutions, and working with the appropriate personnel to implement necessary changes to the work plan. To maintain team morale and work towards the goals of the project, short-term wins and progress at large were monitored on a regular basis by the EMS medical director and PIC director. Ongoing statistics about types of patient visits and demographics were being recorded. Progress was regularly reported to management and staff. Next, we needed to create a more permanent solution and determine how to keep progress going. We wanted to grow and improve outpatient services to provide increased patient education, preventative care, and health maintenance screenings. We knew that doing so would be crucial to us achieving our goals. To do this, our group met with the key stakeholders to create buy-in from administrators like the hospital's CEO, CNO, CFO, and CMO. Planning for a new clinic will begin in November 2018 with the intent of opening a new clinic by February 2019. Currently, we use established providers 1 to 2 days a week to provide care on an interim basis until the clinic is up and running with its own full-time staff. We estimate that the clinic should have 2 physicians, 2 APNs, 2 RNs, and a medical assistant. Finally, we intend to institutionalize the plan and continue to monitor progress and reward improvements. Doing so will mean monitoring the statistics for the new clinic during the first year of operations, which would be February 2019 to February 2020. Additionally, it means continuing to rely upon the 5 pillars and 9 principles to maintain employee satisfaction and participation in the goals and the vision of the new clinic. The outcome of our project overall is to improve care delivered to all patients and improve healthcare coordination. Our goals include empowering staff to care for the diverse population, including the influx of refugees, enhance care provided in the ED by providing care coordination at discharge, developing a new primary care clinic to be available for non-emergent medical needs, and through these endeavors, reduce non-emergency visits to the emergency department. Empowering the staff who work on the front lines will be important for reaching our goals. Urgency has been created to make a change in the department, and servicing the needs of the diverse population has been identified. Staff have identified frustration and increased perception of workload when dealing with the increased diverse population because they do not have education or tools to appropriately care for the diverse community. Staff will be trained and educated on the diverse cultures of our ED serves, including the influx of refugee patients. Staff will be educated on religion, diet, cultural practices, and resources available in order to make our ED more inclusive to the changing demographics of the community. Not only do we want patients to feel comfortable and cared for in our department, we want staff to feel equipped to care for our patients and to be given the tools they need to ease the workload when dealing with diverse populations. Our goal is to have a 25% improvement in perceived workload and diverse care delivery from frontline staff within the first year, and greater than 75% in the second year. The committee members that will be involved include the Emergency Medical Services or EMS Medical Director, EMS Nursing Manager, Lead EMS Nurse Practitioner, Social Services Director, EMS Project Improvement Center or PIC Project Director as well. Nurses, doctors, techs, and ancillary staff will also need to be involved as they are on the front line. Champion members will be identified to lead and demonstrate change in order to evoke staff buy-in. At the end of the first year post-implementation, we saw a 26% improvement in perceived workload, followed by a 75% improvement at the end of the second year, thus making our stated goals. The influx of refugee patients and the already diverse community is cared for with a standardized care plan. Creating an ED environment where care delivered is patient-centered and welcoming to the diverse community is the vision of our department. Staff will be given the tools to make all patients feel welcome and cared for individually, regardless of religion, race, or culture. Language barriers will be reduced as new resources for language interpretation will be brought to the department. Appropriate communication through reducing language barriers will assist patients in following us appropriately instead of returning to the ED when not indicated. We want all patients to feel safe in our ED and feel comfortable as they are cared for in our department, and improving culturally competent care is our goal. Improving patient satisfaction, and specifically culturally competent care, will be measured by Press-Ganey scores. We aim to have a 20% improvement in the first year and a 50% improvement by the second year. Press-Ganey scores are displayed in our break room and will continue to be displayed so staff is aware of our scores. Improving culturally competent care for our patients will require involvement from all staff members, including the EMS Medical Director, EMS Nurse Manager, Lead EMS Nurse Practitioner, Social Services Director, EMS Project Improvement Center or PIC Project Director as well. At our 1-year post-implementation mark, Press Ganey scores showed an improvement in patient satisfaction of 19%, just shy of our 20% goal, but a 52% improvement at the 2-year mark. Social media ratings and comments in regards to the care provided are overwhelmingly supportive and positive in regards to the changes made. Our ED has been overcrowded and busy with non-emergent cases. An overcrowded emergency department leads to decreased throughput, increased wait times, poor patient satisfaction, poor staff satisfaction, and places patients and staff at risk for injury. Ensuring that patients have appropriate follow-up in place and education about using the emergency department can help reduce ED visits. Setting up a primary care clinic is a virtue of the hospital system to help bridge this healthcare gap. Our goal is to have patients feel that they have improved follow-up and that our community health assessment data shows a 10% improvement of perceived availability of primary care available to them. Within 2 years, our goal is to have 50% improvement of follow-up with primary care providers rather than returning to the ED for their follow-up. Once again, this outcome will necessitate involvement from all team members, including EMS Medical Director, EMS Nursing Manager, Lead EMS Nurse Practitioner, Social Services Director, and the EMS PIC Project Director. Within a year of creating the new outpatient clinic, a community assessment showed that roughly 15% of the community felt that they had adequate access to primary, urgent, and emergent care. There has also been an increase in the number of community members with a listed PCP and increase in ED follow-up of 53% in the 2 years following project implementation. Our overarching goal is to reduce non-emergent visits through the efforts of improving care coordination, improving culturally competent care, and opening a primary care clinic. Overcrowded emergency departments is a national crisis, and reducing non-emergency visits can improve outcomes for patients. When emergency departments are overcrowded, patients see longer wait times, delayed treatment, decreased patient and staff satisfaction as well. With our other outcomes and vision in place, we hope to reduce non-emergent visits to our ED and improve the care we give to the community. This outcome will require strong stakeholder support from all those involved, including EMS Medical Director, EMS Nursing Manager, Lead EMS Nurse Practitioner, Social Services Director, EMS PIC Project Director as well. This goal may take time to be realized, but we are optimistic that using Cotter's model for change, we can achieve our goals. Throughout this change in process, advocacy was a huge factor in regards to patients, the community, but also staff. Advocacy first starts with ensuring that the patient who walks through the door receives the care that they need by feeling comfortable asking questions and describing their concerns. To assist with this, in-person interpreters will be available to assist with communicating with providers. Educational materials will also be available in the most prevalent languages of the community. Through educating patient care staff and adding additional case and social workers to the department, the organization will be able to better advocate for this population's specific needs and direct them to the needed resources. By educating patients and providing them with resources, patients will be better self-advocates for themselves and their families. At the same time, by creating a new clinic with staff trained on the needs of this population, the organization is working on community advocacy and social justice. This organization believes that every individual deserves high quality and individualized healthcare, which will be obtained through this project. Social media will be utilized once the new clinic is up and running to help share walk-in wait times and availabilities of providers. Perhaps most importantly, the organization will advocate for the staff by ensuring everyone is educated in their roles, as well as on the needs of the community. Ensuring that staff is educated and working within their scope allows for safe, high-quality care that is more efficient to keep wait times and stay times down. The organization will also work with state political leaders to ensure that providers are able to work to the full extent of their license. This will ensure that all nurse practitioners and physician assistants are able to use their knowledge and skills fully to aid in the care of the community. After the initial goals of the project are met, future steps and goals will include continuing to grow and expand outpatient services to continue to meet the needs of the not only growing but also changing community. Continuing to grow the clinic system will help maintain the appropriate usage of emergency services, keep costs down, as well as keep the community healthy. In addition to growing the clinic system, a future goal will be adding a support and educational group to assist the refugees in acclimating to the United States. By providing this free service, the organization will be investing in the community. Lastly, a long-term goal would be to develop a mobile clinic to assist lower-income neighborhoods who are unable to routinely access healthcare due to work and/or lack of transportation. Creating a mobile clinic will continue to improve upon the organization's goals of decreasing non-emergent ED visits, decrease expenditures, and increasing both patient satisfaction and overall health. Overall, Cotter worked well in promoting change for this case. We were able to develop ways to ignite urgency and passion for the problem, all while creating better communication among the organization. However, if we were to do this again, Studer also would work well and also has tools such as the 5 pillars and 9 principles to set in place to continue to open communication needed to aid in necessary changes in the future. And here's a list of the references that we used in our presentation, and I appreciate your time.